Belum lagi ya. Okay lah.
Good afternoon, ladies and gentlemen. Thank you for joining us on this event for Women's Global Health Lecture Series webinar. My name is Kuhan. I'm a fourth-year medical student, and on behalf of Taylor's University, I would like to extend a very warm welcome to all of you. We appreciate you taking time off your busy schedule to join us today. We hope that you will find this program fruitful and engaging. Before we begin, I would like to introduce the agenda for today. So we have three distinguished speakers for today, and we also have a Q&A session, which is done after the speaker's topic. And also, we would like to encourage you to type out your questions in the chat box so we can read it out to the speakers. As for the MMB CPD points, we will show QR code later after the Q&A session. Now, I would like to introduce our first speaker, Emeritus Professor Dr. Yip Cheng Ha. Professor Emeritus Dr. Yip Cheng Ha is currently a consultant breast surgeon in Ramsay Sime Darby Healthcare Center in Malaysia and is a lead clinician for the Breast Cancer Research Program in the Cancer Research Malaysia. Dr. Yip began her surgical training in 1982 when there were only a handful of women surgeons in Malaysia. She obtained her FRCS Glasgow in 1985, after which she started her academic career as a lecturer in UM in 1986. She also was an associate professor in 1993 and a full professor in 2000. She retired from UM in September 2011 and was conferred Professor Emeritus by the University of Malaya in October 2016. She has 225 publications in peer-reviewed journals, mainly on breast cancer in the Asian setting, with a H index of 34. She was a past president of Association of University Surgeons of Asia from 2003 to 2005 and was the first woman surgeon to be the president of College of Surgeons of Malaysia from 2010 to 2013. She was the president of Breast Surgery International from 2015 to 2017, and she is currently the president-elect of the International Surgical Society. In 2009, Dr. Yip was awarded the UICC Research to Recovery International Health Professional Award for her work in breast cancer, and in that year was also awarded the Malaysian Greatest Woman of Our Time Award. Without further ado, I would like to invite Emeritus Professor Dr. Yip Cheng Ha for her presentation on familial or hereditary breast cancer.
Thank you very much for the introduction. Can you hear me?
Yes, Prof.
Okay, good. I'm going to be talking about familial or hereditary breast cancer. Is there any difference between familial or hereditary? There is actually. Familial means it's a clustering of cancers in a family by chance. Could be a combination of genetic and non-genetic factors. Hereditary means there is an alteration in a single gene and there are multiple generations of breast cancer. More than one cancer and more often is a bilateral. And BRCA1 and BRCA2 autosomal dominant inheritance with a very high penetrance is the commonest hereditary breast cancer. And so this is the difference between the two. What genes cause increased breast cancer risk? There's at least 10 breast cancer genes, but the commonest is BRCA1 and BRCA2. You can see the red part, there are lots of genes that nobody has discovered yet. So you can have a very strong family history, but we cannot find any mutation. So besides BRCA1 and 2, the more rare ones that we test for are TP53, PALB2, ATM. You know, these others are not that common. So we only talk about BRCA1 and BRCA2 because that's the commonest. As you can see here, this is 1% of the population. Only about less than 1% of the population have BRCA1, 2, P53, P10. So these are very rare ones. And CHEK2, ATM, PALB2. So these are the high, and this one relative risk is the highest over here, but small percentage of the population. These are more common, but they have very low relative risk of getting breast cancer. Now, the BRCA1 gene was discovered in 1993. You can see this was the Newsweek front cover when they discovered the breast cancer gene. And this is the gene that was covered later and it was published in Science 1994. This was followed by discovery of BRCA2. So when I was a medical student, they haven't found the breast cancer gene yet. Now, this is the cumulative risk. If you look at BRCA1, the risk of having breast cancer, this is the cumulative risk, is about 70% by the age of 70. This is the sort of risk we always give. So just because you have BRCA1 or 2, it's not 100% you will get breast cancer. So why is it some women will escape their genetic destiny? This is something that we don't know. There are probably modifiers in your environment which will prevent you from getting breast cancer even though you have a BRCA mutation. The BRCA2 has a lower risk of developing breast cancer in a woman's lifetime. You can see it's about 50% by the age of 70. Now, this lower line is the ovarian cancer risk. BRCA1 and 2 is associated with ovarian cancer as well. And it increases, it's about 40% in BRCA1, but only about 10 to 20% in BRCA2. Now, BRCA1 and 2 is also associated with contralateral breast cancer. If you look at this, this is a published data. It's about 50% at 10 years. That means if you have a breast cancer on one side and you are BRCA1 or 2 carrier, there's a 50% chance you will get breast cancer in your opposite breast. In a normal woman without a BRCA, the chance of getting opposite breast cancer or contralateral breast cancer is only about 5% in a normal woman. And this is a study that look at penetrance. If you know genetics, you can have a mutation. Penetrance means the chance of your mutation actually causing cancer. I've already talked about the penetrance rate, which was here. Okay, this was what was originally published in 2003. But there are many studies, like it may be different in different populations. So this one is BRCA1 cancer risk. This is another penetrance study, 60% for Brca1, 55% for Brca2. But Brca1, they gave a contralateral breast cancer risk of 83%, which was higher than the initial study, and ovarian cancer 59%, which is very high. So different studies may give you different penetrance rates. Okay, now we started the Malaysian breast cancer genetic study in 2003 when I was in the university. This was a MOU between University Malaya and Cancer Research Malaysia, which was the led by Prof. Teo Su Huang then. She's a very brilliant molecular scientist. And from 2003 to now, we have actually done almost everything on breast cancer genetics. So based on this big study in 2016, we published a hospital-based series of breast cancer cases. And in, let's say in all the breast cancer patients, the chance of having Brca is 5.3%. So BRCA is not common. So even in 100 breast cancer patients, only 5.3% actually have a BRCA mutation. But if you look at the normal controls, this is the hospital-based series of healthy controls. These are people with no breast cancer. That means in the normal population, only 2 out of 1,000 people in the public are Brca carriers. So like you and me, no breast cancer, we only have a 1 in 500 chance of being a BRCA carrier. So this is also what we have published, you know, after we have collected 3,000 over cases, almost 4,000 cases and 4,000 controls. And you find that the highest risk, 38.6%, are women who have a first-degree relative with ovarian cancer, okay, 38.7, followed by male breast cancer. Now, male breast cancer, if you have a family history of male breast cancer, the chance of having a mutation is very high. And based on this, we have got this, you know, we have a management of breast cancer clinical practice guidelines, and this is the 3rd edition, which was just published in 2019. This is the latest edition of our clinical practice guidelines, which talks about genetic testing criteria. Obviously, you can't test all women with breast cancer for BRCA because your chance of getting a positive Brca is only 5%. And Brca testing used to be really expensive. But I have to tell you, with time, the cost is getting less. It's only 3,000 ringgit now. It used to be 6,000 ringgit. Okay, so genetic testing, it's not just you can just test the woman, you need genetic counseling. Doing a genetic test is not the same as doing a tumor marker in the blood, which is cheap, or doing hemoglobin in the blood. Okay, that's totally different. A genetic test looks at the DNA. It's a germline mutation that affects your whole family. If you carry a mutation, and this is a dominant, an autosomal dominant mutation. Autosomal dominant for our medical students here, if you carry an autosomal dominant gene, every child you have a 50% chance of carrying that gene. So this affects your whole family. Okay, and these are the testing criteria. Even if you don't remember anything about my lecture, remember this. This is the criteria for testing. Okay, take a photo of this. This is the criteria for testing in women with breast cancer. Okay, these are women with breast cancer, not just the normal public. These are only women with breast cancer. So if you have ovarian cancer, breast cancer diagnosed less than 45 years old, 2 primary breast cancers. Some women have 2 bilateral breast cancers, and that one is also a higher incidence of carrying a mutation. If you look at this, bilateral breast cancer, 16.1%. Anything more than 10% chance is actually a reason for testing already, because in the normal person it's only 5%. Triple negative breast cancer diagnosed less than 60 years old. Because triple negative, I want to talk about what triple negative is. It means you are ER negative, PR negative, HER2 negative. This is the subtype of breast cancer you have. Male breast cancer, and breast cancer plus a parent, sibling, or child with any of the above criteria. It means you have breast cancer, your mother has breast cancer when she was less than 45 years old, or she had 2 primary breast cancer. So these are the things that would mean that you can actually test for the gene. The survival in BRCA1 is no different from controls. Most studies show no difference in survival, except for one little study that showed that BRCA1 associated breast cancers had a poorer survival. But this is because BRCA1 breast cancer is very likely to be triple negative, which has a poorer survival. Okay. Now, is there any difference in the pathology of BRCA-associated breast cancer? Now, breast cancer is not one disease. It's actually many different diseases. Some people, one molecular study actually said breast cancer is actually 10 different diseases, you know. But for purposes of treatment and prognosis, they are usually subtyped into 4 types based on the estrogen receptor, progesterone receptor, and the HER2. Okay, so the best prognosis is this one, ER positive, PR positive, HER2 negative, which is the 47.5%. These are studies that we did in and this is the study that was published from Kuching, Sarawak by another group, Bina Devi, another group of authors. So if you look at the case, which is Peninsular Malaysia, the commonest type is the ER positive, PR positive, HER2 negative type. And this is actually the type with the best prognosis. The worst prognosis is the ER negative, PR negative, HER2 negative type, which occurs in about 20% of cases in Peninsular Malaysia. If you look at East Malaysia, 29% is triple negative. And this is because the indigenous group there, the indigenous people, you know, the tribes there have a higher incidence of triple negative breast cancer, because the types of breast cancer actually can be determined, can be different in the different ethnic groups. So BRCA1 is very often triple negative. You look at this, almost 100% were triple negative. BRCA2 is the same as other spontaneous breast cancers. Okay, so there are different pathological differences in the triple negative rate. So if we know a woman with breast cancer has a genetic mutation, will it change the way we manage the cancer? I'm going to talk about 3 scenarios management of BRCA. This was a lecture I gave before, mainly on the surgical management. So the first scenario is you have a woman with breast cancer, strong family history, had surgery for breast cancer, underwent genetic testing after treatment. That means at the time she was diagnosed, we do not know the genetic, the mutation status. Because at the time of diagnosis, most people don't test for genetic status because testing costs 3,000 ringgit and you have to counsel the woman and she has to decide. Sometimes you have to give her time to decide. I will talk about genetic testing later and counseling later. So, but after everything, you know, maybe even 1-2 years later, she decides she wants a genetic test and finds a BRCA mutation. Do we do anything further about her cancer? So that's the first scenario. The second scenario is a woman newly diagnosed with breast cancer, strong family history. She had genetic testing at diagnosis. Not very common, but increasingly now we do have women who have got a genetic test at diagnosis, found to have a BRCA mutation. How will it affect your management? So here you have a new patient, not treated yet, BRCA positive. It's going to change your treatment, your surgical treatment. And the third scenario, you have a woman without breast cancer, BRCA mutation in her family, but she did a predictive testing. Predictive testing means is a woman who has got a family history or her family is known to have a Brca mutation. So you test her for Brca. That means the testing is to predict whether she is positive or not. How would you manage her? So a perfectly normal woman, no breast cancer, but Brca positive. Now surgery has evolved from radical mastectomy to modified radical mastectomy to breast conserving surgery and to oncoplastic breast surgery. That means reconstruction. Okay, so in the first scenario, a woman already had breast cancer. She had breast conserving surgery followed by radiotherapy. Now, is breast conserving surgery safe in BRCA carriers? Or she had already a mastectomy. What next do we do? This is the most common scenario. Now, mastectomy or breast conserving surgery, is there any difference? Okay, all these are studies that were done. Comparing Brca mutation and carriers and non-carriers who had breast conserving surgery, overall survival is the same. But BRCA mutation carriers may have an increased risk of local recurrence in the long term. Okay, this is the conclusion. So survival is the same. So you can do lumpectomy or mastectomy. It does not matter. Okay. And these are again another meta-analysis, also found no significant difference. This one had no difference in local recurrence. But if you follow up longer, there was a significant increase in local recurrence. So BRCA carriers, lumpectomy, mastectomy, no difference in survival, but a higher incidence of local recurrence. Now, in TP53 carriers, radiotherapy is detrimental. So in TP53 carriers, if we know she's TP53, we usually advise a mastectomy because mastectomy, you don't need radiotherapy. But in BRCA carriers, okay, big review found no impaired survival and no increase in adverse effects due to use of radiotherapy in BRCA mutation carriers. So that means you can do lumpectomy followed by radiotherapy in mutation carriers. Is it safe? Now, the other issue, like in this woman who's already had one breast removed or had lumpectomy on one breast, her contralateral breast cancer risk is high. Different papers, different values, but I usually tell patients it's up to 50% chance of metachronous contralateral breast cancer. So if she wants a contralateral prophylactic mastectomy, we call it CPM, contralateral prophylactic mastectomy. It is okay, we will do for you. Okay, but in the risk of contralateral breast cancer in non-carriers is only 5%. So in those breast cancer patients who do not have BRCA, we usually don't take out your opposite breast, okay? So it's showing an increasing trend in the Western world, even in those who have actually no mutation. Okay, because women, because of the increasing availability of breast reconstruction, if you take up both your breasts and do reconstruction at the same time, it actually gives more symmetry. Okay, and even though the women do not have a BRCA mutation, a lot of them are actually opting for a contralateral prophylactic mastectomy. Now, in BRCA carriers, does contralateral prophylactic mastectomy improve survival? This is a retrospective study. So we actually, it does say that CPM are less likely to die from breast cancer than women who are treated with unilateral mastectomy. So it does have a survival benefit, but as a retrospective study, small events, so I'm sure the statisticians will know the only level 1 evidence is if you do a prospective randomized control trial, which I think you can't do in this sort of case. Okay. So the Association of Breast Surgeons in the US actually says that CPM should be considered for women at the highest risk of contralateral breast cancer, specifically women with deleterious mutations of Brca, a greater than 25% lifetime risk of breast cancer due to family history in the absence of deleterious mutations, or a history of mental radiation, usually Hodgkin's lymphoma before age 30. So this society says that in these 3 instances, you should offer CPM. But for average risk women, you do not benefit from CPM, and thus CPM should be discouraged. Okay, in other mutations such as CHEK2, PALB2, CDH1, there's actually no evidence about contralateral breast cancer risk. The contralateral breast cancer risk seems to be confined to BRCA1 and 2. So what is the uptake of prophylactic contralateral mastectomy in women in affected Brca carriers? Not many, 35% requested bilateral or contralateral mastectomy, 49% requested oophorectomy. So it's actually not 100% of women will want, because you offer them the choice. Now, this is the second scenario. A woman newly diagnosed with breast cancer, strong family history, did a genetic test at diagnosis, found to have a Brca mutation. How will it affect your management? This is what I mean, the genetic testing, treatment-focused genetic testing. That's a new term we use. That means we are doing genetic testing because it can affect the treatment, the choice of treatment. Okay, so when should genetic testing be conducted? Is it in newly diagnosed? So this is a study that showed that there was 194 newly diagnosed patients, all with 10% probability of having a Brca mutation. They underwent accelerated testing, which means you get the results in 2 weeks. Otherwise, it takes 3 months. 49% of Brca carriers chose to have bilateral mastectomy. That means if you know you are a BRCA carrier, you just want to take out both your breasts because at the same time, because the risk of contralateral breast cancer is so high. So this is called treatment-focused genetic testing, combined curative and prophylactic surgery in Brca-positive breast cancer. So one breast is curative, the other breast is prophylactic. Okay, so the treatment-focused genetic testing before surgery provides Brca carriers with the opportunity to reduce the need for separate surgeries for treatment and prophylactic prevention. Because if you do not know this, you do one breast first, and then maybe a few years later, you do the other breast. Okay. So with the advent of such genetic testing, Brca carriers are less likely to choose breast conserving. Well, because if you are Brca and you need to take out your opposite breast, which needs a mastectomy, then you might as well take out both breasts and do a reconstruction at the same time. However, if a patient comes with very advanced disease or metastasis has already occurred, the patient is more likely to die of breast cancer before they get a contralateral breast cancer. So bilateral mastectomy is not recommended as it offers little benefit. So again, you don't offer CPM if the patient has got metastasis, because they're more likely to die of breast cancer than of a second, and then before they develop a contralateral breast cancer. Okay, now the problem with doing pre-operative genetic testing is that there may be insufficient time to understand the information about the risk. You lead to a rash, extreme decision made in the heat of the moment. Okay, so it's quite important that the woman takes time to understand the implication of a positive Brca test. Okay. In addition, without sufficient time to make a considered decision, there may be higher risk of longer-term feelings of regret. Regret means they regret doing the test. They regret taking up both their breasts. Okay. So the third scenario, woman without breast cancer, Brca mutation in her family, predictive testing shows Brca. How would you manage her? So you have no cancer, but you know you have Brca. What can you do to reduce the risk? Because this is your genetic destiny. You cannot change your genes. First, if you don't want surgery, you can go for early detection, mammogram, MRI, breast ultrasound, pelvic ultrasound. So you will keep worrying. The surveillance may not succeed in detecting cancer early. I have to tell you that, you know. Because these are young women, mammogram may not be accurate. You have to do MRI every 6 months, alternate with mammogram. And MRI is very expensive, notoriously expensive. You can do prophylactic risk-reducing mastectomy and prophylactic risk-reducing oophorectomy. So this can reduce the only way to prevent breast cancer and ovarian cancer is to take out your breast and your ovaries. This is the most famous Brca mutation carrier, Angelina Jolie. This was the Angelina effect. This was in 2013. She had a Brca1 mutation, was told that she had an 87% chance of developing breast cancer. She decided to have bilateral nipple-sparing prophylactic mastectomy with immediate reconstruction in 2013, and in 2015, she had prophylactic oophorectomy. After her story came out, lots more women came for genetic counseling and testing. So they call this the Angelina effect. Okay, Angelina Jolie's family history of hereditary breast and ovarian cancer is reconstructed here. You see, this is Angelina Jolie. Her mother had breast cancer. Her aunts had breast cancer. Her grandmother had ovarian cancer. This is a very typical breast cancer family. So you can see that, did she do the right thing? A lot of women actually feel that she has gone a bit overboard with it, you know. But of course, her decision is that she does not want her children to go through what she went through, seeing her mother dying of breast cancer. So this is risk-reducing bilateral mastectomy with and without reconstruction. Okay. We have done with and without. This is indicated for the high-risk women, but the woman should be evaluated by a multidisciplinary team. Reduces risk only by 90%, not 100%, and patient needs to know the pros and cons. You don't need really a lymph node biopsy because this is only a prophylactic mastectomy. Now, why is it you take out your breast is only 90% reduction? Because the skin flaps and even the axillary region could have some breast tissue. And if you are unlucky, that breast tissue can develop a breast cancer. Okay, now, timing, when do we do it? Can you do it in a 20-year-old? But I have heard of women in their 20s doing a risk-reducing mastectomy. And it depends on age of children, of patient, whether she wants to have further children and breastfeed her children. Probably late 30s and early 40s would be a good age. Majority of women opt for immediate reconstruction, and we won't talk about the types of reconstruction because this would be a big lecture by itself. Normally, we do a skin-sparing mastectomy. Also, it's okay to do nipple sparing because the nipple has just very little breast tissue there. With immediate implants is the commonest. It does not require an incision elsewhere. So this is the simplest to do. Okay, now, this one just shows again the risk reduction by prophylactic mastectomy. Okay. And the effect of bilateral prophylactic mastectomy on quality of life is another issue. Okay, though one review showed that 70% were satisfied with the surgery, because it really depends on how good the plastic surgeon is, isn't it? Okay, so basically, a lot of women do not regret doing it. Okay, and they were quite satisfied with the bilateral prophylactic mastectomy. And the high satisfaction could be due to less anxiety over breast cancer. Okay, now the type of surgery used in prophylactic mastectomy, we've gone through this. You can do nipple sparing, and the risk of malignancy following conservation of the areola is 3.5% to 5.5%. So if you leave the areola and nipple alone, you actually can still have a 3.5 to 5.5% chance of having cancer in the nipple areola complex. Okay, sentinel lymph node biopsy is not part of the routine practice. And this is what we do. We do a lat dorsi flap reconstruction. Okay, we do it in the lateral position. So while I take out the breast, the plastic surgeon will raise the flap from the back, and then we finish together, and there she has a new breast. We can do this in like 2 hours if we work together. Okay, so this is a bilateral mastectomy, no recon, and then you have various pictures where recon is done. So you can get actually quite good results. Okay. And you can also use implants. We prefer autologous because implants, they have all this foreign body there forever, you know, and sometimes the implant can give you problems. So I actually prefer to use autologous. Like this one, we are using the patient's tissue from the back. There's no implant. However, this takes longer and you need another incision from the back to get the autologous tissue. Okay. So I'm just going to talk briefly about oophorectomy. The risk reduction salpingo oophorectomy. Salpingo means the tube, usually done after completion of family, late 30s or early 40s. The risk of ovarian cancer is not as high as the risk of breast cancer. There's issue of menopausal symptoms post-op, and the safety of HRT is not known. The risk reducing bilateral oophorectomy was previously thought to reduce risk of breast cancer. That means you take out your ovaries without taking out the breast, it can also reduce the risk of breast cancer. However, 2 large prospective studies found no statistically significant reduction in risk of breast cancer after prophylactic oophorectomy. Okay, so what is removed? You have to remove the tubes because in BRCA, the cancer actually can start from the tubes, you know, from the fallopian tube. That's why you have to remove the fallopian tube. Okay. So what about the uptake of preventative options in unaffected Brca carriers? These are the prophylactic surgeries, no cancer. So most women would rather remove the ovaries and not the breast because the breast take longer. Taking out the ovaries is a quick procedure. And this was similar to what we found in our Malaysian patients. We had one study that we did in UMMC in women who had Brca carriers. Okay, and we find that not many of them actually want to have the prophylactic mastectomy. This is just a case study. This is an actual woman that I had. She's 45 years old on follow-up for breast cancer. At 41, she had a left breast cancer treated by breast conserving surgery, radiotherapy, chemotherapy, and she's triple negative. Her mother has breast cancer, was already found to be Brca positive. So she is actually in the first scenario. She did not want to have Brca testing done. Okay, she did not want. But since then, she's been counseled about risk of contralateral breast cancer and ovarian cancer. She chose to have close surveillance with yearly mammogram and 6-monthly ultrasound. And recent ultrasound showed a new lesion, 1.5 cm, core needle biopsy showed DCIS. So what would you recommend? Another breast conserving surgery of the right breast with radiotherapy, okay? Or a right mastectomy and sentinel lymph node biopsy with left mastectomy with or without reconstruction. And what about the ovaries? Because you can do the ovaries at the same time as you do the breast surgery, okay? Because it's a fairly short, straightforward operation. What did she choose? She actually wanted a right mastectomy and sentinel lymph node with left mastectomy. And she also wanted the opposite breast that had the lumpectomy done, okay? And a bilateral autologous transplant, means not implant, using the lead dorsal flap and fat injection. And she eventually agreed to an oophorectomy a few years later. Decision making by the patient is very important. As doctors, we can help the patient to make a decision, but we cannot make the decision for a patient. She's a well-educated young patient. Okay, so this is a summary of the surgical management. Women with treated breast cancer found to have Brca mutation offer CPM and BSO. Women newly diagnosed, history suggests hereditary breast cancer, offer expedited Brca testing, and if positive, offer immediate CPM and BSO. Women with Brca mutation, no breast cancer, offer bilateral prophylactic mastectomy and BSO. And in all cases, offer reconstruction immediately. What about systemic therapy? There was a small study that showed that cisplatin actually works better in Brca-associated breast cancer compared to the usual CMF, anthracyclines or the taxanes. Okay, but this is not a very, very small study, number of patients 12. So most oncologists do not actually, for adjuvant therapy, do not actually do anything different. Okay, most of them will still use the anthracyclines and the taxanes. Okay, now a new group of drugs called PARP inhibitors came on, and this is PARP inhibitor. Wow, this is a very complicated thing, but it's a use of it's a DNA repair enzyme. It selectively kills the tumor, and it's a new concept in cancer treatment. So there's two PARP inhibitors that's FDA approved for breast cancer. Olaparib and talazoparib are approved for metastatic breast cancer in 2018. And recently in November 2021, olaparib was approved for use in early breast cancer as adjuvant therapy. So now there is a reason for women to get tested, because this study showed that 1 year adjuvant treatment of olaparib significantly reduced risk of recurrence or death by 42%. Good safety profile. So early knowledge of Brca status is critical in informing treatment decisions. So this Olympia trial, this is AstraZeneca drug, olaparib, is the first to report benefit of a PARP inhibitor as adjuvant therapy in patients with G-BRCA, means germline BRCA mutation. That means it's in your blood, it's a genetic mutation. HER2 negative early breast cancer. Now, so since there's a drug, why don't we treat everybody for BRCA? But again, I have to remember the guidelines, you know, for genetic testing and counseling, okay? Not all women are suitable. And the other thing is, olaparib is 24,000 ringgit a month. That's enough to stop anybody from doing it. So this is treatment-focused genetic testing. So again, I said that pre-operative genetic testing, there may be insufficient time to understand the information about the risk. But because there is a drug developed for Brca carriers, it may help in deciding on the treatment. To do genetic counseling and testing, you need a multidisciplinary team. And in we started a genetic counseling clinic, okay, for breast cancer. You need a geneticist, a counselor, you need the x-rays, you need the patient in the center, the lab, the surgeons, the family, the oncologist. So this is a sort of a multidisciplinary team that is needed. And genetic counseling and testing is a multi-step process. You have to identify at-risk patients. That means your clinical practice guidelines, okay? Provide pre-test counseling, provide informed consent, select and offer the test, disclose the results, provide post-test counseling and follow-up. So You know, this is the process of genetic test counseling. You cannot test without counseling because the patients need to know the benefits and limitations. I'm going to quickly go through this. Some patients don't want to know, so they don't want to do. In Asia and in Malaysia, it's very difficult to do risk assessment because of inaccurate family history. Breast cancer is a stigma. I can tell you my mother-in-law has breast cancer, but her sisters do not know because of the stigma. They don't tell their family. Okay, complicated families because there's so many members and difficult to verify cancer history, especially ovarian cancer. They will say that they have cancer in the, somewhere down there. Okay, it could be uterus, it could be cervix, it could be ovary, but women don't know which organ, so very difficult. And there's no regulatory guidelines because in this country, the insurance has not made any statement to protect women with genetic mutations, because in US, you have the GINA, the Genetic Information Non-Discriminatory Act. That means even if you are Brca carriers, the insurance will have to insure you. In this country, they don't even insure you if your mother has breast cancer, isn't it? Even without the genetic testing. And clinical management options are limited. They may not have access to MRI screening, which is the best screening for Brca carriers, and you may not have access to prophylactic surgery and reconstruction. And lack of access to Brca testing because there's not enough genetic counselors. You need to be counseled for 1 hour before you actually do the test. Hesitation among healthcare professionals because it's a trade-off between the benefit and the consequences of genetic discrimination and how to interpret complex test results. Lack of knowledge about the impact of genetics on the individual and family. There's a lot of psychosocial barriers. This is the latest paper we did. We now actually have a calculator for predicting the likelihood of carrying a Brca1 and Brca2 mutation in an Asian patient. Previously, you have models that were based on the Caucasian patients, like the Manchester score and all that. So this one was just published 2022, fresh off the press. This is from our genetics group in the Cancer Research Malaysia, and SJMC. And I would like to acknowledge this whole big group in Cancer Research Malaysia, University Malaya, and the SJMC now, with funding from all these organizations, okay, to be able to make our research possible, so that we have our own data on the Malaysian breast cancer genetics. Thank you very much. This is my last slide. Are there any questions, or we save it for the last?
Thank you, Prof. Dr. Yip Cheng Ha, for the informative session. I think now we can begin the Q&A session regarding Prof. Yip's talk on familial and hereditary breast cancer. Dear participants, please type out your questions in the chat box so that Prof. Yip can answer them quickly now.
If not, I can come back later at the question and answer question at the end of this session. I think about 5:50, I think it was. Then you can proceed with the next lecture first. Is that okay? You can write the questions on the chat. I will look at it and I will answer it in the chat box. Okay?
Okay. Okay, so it is my pleasure to introduce Prof. Yip. Can you unshare your screen?
Yes, I'm looking for the unshare one.
Okay.
Oh dear. Sorry. I have to. Okay, I think I got it.
Okay, it is my pleasure to introduce our second speaker, Associate Professor Dr. Eugene Leong. So Prof. Eugene is an Associate Professor in ONG in Taylor's University School of Medicine. He received his undergraduate degree from the Faculty of Medicine, University of Malaya, and obtained training under Dato Emeritus Professor Dr. V. Sivanesan Ratnam, FRCOG for MRCOG in the University Hospital, Kuala Lumpur. At the same time, MOG in Malaysia, and later FRCOG in UK, conferred in 2010 by the RCOG UK. He also did his subspecialty training in minimally invasive surgery from attachment in fellowship training, MIS unit, Kandang Kerbau, Women's and Children Hospital in Singapore for 3 months in the year 2000. He also received numerous awards, including Overseas Fund Award, RCOG 2001, Minimal Access Therapy Training Unit, Royal Surrey County Hospital, Guildford, UK, and also attachment to Professor Christopher Sutton and also Mr. Andrew Kent in the NHS. Today, he will be sharing us about post-menopausal bleeding and endometrial cancer. Let's welcome Prof. Eugene to deliver his speech.
Okay, hello. A slide, please, Mr. Kumar.
Yes, Prof. I'm sharing your slides.
Okay, we're going to talk about post-menopausal bleeding and endometrial cancer. As you can see, most women who are menopause do not expect to have any bleeding after the period stops. That's why there's an arrow there, and post-menopausal bleeding is a bit tilted intentionally, yeah, to point out the fact that most women who are menopause in Malaysia is 51, 52, 53, 54. The oldest woman whom I've seen who's still menstruating is age 56, and she still has got regular periods. Next slide, please. Okay, in 2022, I actually received very good news. One of my previous patients who I operated 13 years ago told me that she had endometrial cancer and operated by me and given chemo. She's still alive and still very well. And she's now retired. She's doing some voluntary work and she's doing very well and no recurrence. And that was a very good news. So that's endometrial cancer. You can survive endometrial cancer if you present early. Next slide, please. Now, what causes postmenopausal bleeding? I think a few days ago, I just saw a lady who had postmenopausal bleeding and brought by one of her relatives. And she actually has got breast cancer, operated a couple of years ago, and she's on tamoxifen. And then she had some irregular bleeding a few weeks ago. So if you have breast cancer and you're on tamoxifen, it can also cause irregular bleeding. And sometimes it is fresh red blood. Some patients may say it is just some chocolate staining which she needs to use panty liner maybe one a day, not a lot. Some patients really have a lot of bleeding. They will need 5 or 6 pads. Some even wear Pampers, and I've seen patients like that. Some of it comes out with big blood clots and chunky blood clots. Some just have some brown, black color staining on the underwear, which doesn't require a pad. And some have some pinkish light discharge. And they say, no lah, it's nothing. Maybe it's a urine infection, you know. But whatever it may be, there is blood. And that is not normal, especially if they have reached menopause. I will come to what is the definition of menopause in a moment. Some patients may have got some yellowish discharge on the underwear or on the panty liner, which they use for hygiene purpose. And they found that there's a little bit of blood, just 1 or 2 drops of blood. It's not like a lot of bleeding, you know. And some patients will tell you they got bleeding after intercourse, right? So there are many ways to present with postmenopausal bleeding, and many of them actually are not on hormone replacement therapy. So that, and some of them may have taken Chinese herbs, you know. Yes, next slide, please. So for some women, what if they haven't menopause yet? They haven't menopause yet, they are age 55 and they have got irregular vaginal bleeding. Do you call that as postmenopausal bleeding? Well, we use the term perimenopausal bleeding. That means they haven't reached the menopause, they are still menstruating, they may be 49, they may be 50, they may be 55, they may be 54. They have got periods maybe 3 times a year, you know, not every month now, but they're still having some periods. So they're not considered menopause yet. So this is called perimenopausal bleeding. Now, if you see a general practitioner, many of them will just give you some contraceptive tablets or some progestogen tablets to stop the bleeding, but they have not arrived at a diagnosis. They assume that it's just a normal, irregular perimenopausal bleeding and not having ruled out any endometrial cancer or any cancerous growth. Then that's not very good. You need to rule out other causes. Next slide. So what is the definition of menopause? Supposing if you have stopped your period for 1 year, if you have got hot flushes, if you have got a dry vagina when you have tried to have relations with the husband, is very, very dry and very discomforting. When you have got mood changes, when you get night sweats, when you check your blood for FSH and LH, which stand FSH is follicle stimulating hormone, LH is luteinizing hormone, and is very high. Usually is more than 10, and your skin is dry, and maybe if you check your bone, you have a little bit of osteopenia or osteoporosis starting. So that is the definition of menopause. So if you've only stopped your period for 9 months or say 6 months, you're not menopause yet until you reach 1 year. Okay. Next slide, please. Now, I have seen some patients who the bleeding stopped for 1 year and then they didn't get bleeding. And then the following year, they got 3 or 4 periods. So is that menopause or not? That the answer is no, right? They must be stop and stop, really, really stop. Now, menopause can occur naturally, meaning you are 53, you didn't take anything, you didn't take any medicine, you didn't take any supplements, and the period stopped, right? And she still has the uterus and the cervix and the fallopian tubes and the ovaries are still there, and she just stopped menstruating. Now, for some patients, maybe they had menopause due to they had operation. The uterus is removed either for cancer or for fibroid, or they had DUB, very common, dysfunctional uterine bleeding. There are a lot of bleeding that didn't respond to treatment and they had no choice, the doctor had to remove the uterus. Now, some patients may have had radiotherapy, say for colon cancer, and the ovaries have been in the field of irradiation, so the ovaries have stopped functioning. Some patients may have had uh, not a good experience. They had breast cancer when they were in their 40s, they had operation, then they had chemotherapy, and then they had some other illness, and then they had further chemotherapy, or they had breast cancer, they had chemotherapy, operation, radiotherapy, and then the breast cancer recurred. Then they had some more chemotherapy. So that can cause the period to stop. And some may be on certain medications. Next slide, please. So what else can cause postmenopausal bleeding? As we have mentioned, it could be they are on hormone replacement therapy. They are supposed to be on every day, but they forgot to take for 3 days, then they take it back again. Then they forgot to take another 2 days, then they take it back again. Because of the fluctuating hormone levels, it can cause postmenopausal bleeding. But nowadays, not many people use hormone replacement therapy because they're all worried about breast cancer and heart attack and stroke. So, but there are still certain patients on hormone replacement therapy. Now, I have seen some patients who take some herbal medication, say they go to some country and a relative bring back some herbal medication and say it's very good for you, you must take, then they boil and they drink it, then they get bleeding. Sometimes we do not know what the ingredients of this herbal medication is, and then they end up with bleeding, and then they become very panicked, then they go and see a doctor. The other thing is maybe the patient is not menopause, right? Maybe the patient is not menopause, and the patient is still actually having her period, but she jumped the gun and she says she's menopause. Of course, we still have to check why she's having irregular bleeding. Now, there are a very few patients who are on medicine that makes the blood don't clot, like on warfarin or some injection or some other medicine that causes the blood not to clot, given by doctors. Some patients actually have cervical polyp. Some patients actually have cancer, endometrial cancer, cervical cancer, but that is for the doctor to examine and to see and to do the relevant test to check whether the post-menopausal bleeding is really serious or not. Now, I have seen in my life about less than 10 patients with an ovarian mass with estrogen secreting tumor. That means the ovary is producing estrogen, although they are menopause. So it causes and triggers the uterus to have bleeding. So the ovarian tumor is very small, maybe 3 by 4 cm. It's not big, not like a huge 7 or 8 or 10 cm mass, very small. But when we send it for checking after the operation, they actually found that it's an estrogen secreting tumor. So very often patient ask, when I do a scan, they say, doctor, if the mass in my ovary is 3 by 4 cm, is it cancer? It's so small only, So that is a difficult question to answer when we have not done all the tests. Of course, other things can be due to trauma. Maybe they had a new boyfriend, things like that. Okay. Next slide, please. So what exactly is endometrial cancer? Endometrial cancer means the uterus consists of the uterus, consists of the ovaries and the tube and the cervix. The endometrial cancer is the one that comes from the lining of the womb. That means the lining of the womb, every month when you get your period, that lining comes out. Now that becomes cancerous. That is endometrial cancer. Of course, other things, as we mentioned, it can be cervical cancer. What is a uterine sarcoma? Uterine sarcoma is when the body of the uterus itself becomes cancerous. Not just the lining, the body of the uterus, the actual body of the uterus becomes cancerous. Now, endometrial hyperplasia can also cause bleeding, meaning this is something that has become abnormal, but has not reached the stage of being cancerous yet. And usually we can only diagnose this either using a PPEL or a DNC. How many patients do have polyps? Well, in a month, I can see maybe 1 or 2 patients with polyps that cause irregular bleeding. And once we remove the polyp, which can also be non-cancerous or cancerous, and we have to send it for checking in the lab before we can tell you what it is. Fallopian tube cancer, how many have I seen in my life? Less than 10. But it does exist. That means the fallopian tube becomes cancerous and it causes bleeding to come down from the fallopian tube into the uterus. And it causes irregular bleeding or some very foul-smelling, dirty colored discharge coming out. Not really blood. Okay? Yes. Next slide, please. Now, very uncommon. Some papers have reported a patient actually has a lymphoma in the cervix. Lymphoma in the cervix is just like in the layman's term, they got leukemia in the cervix, lymphoma. Of course, I'm not a lymphoma expert, but for the lay person, there is something like cancer of the blood. Now, choriocarcinoma in people who are 50, 60, 55, not common, but it still can happen. It could have been due to a pregnancy many years ago and it become cancerous. We can also have got vaginal deposits. Last time I saw a patient with a tumor in the cervix, but when we biopsied it, it turned out to be a breast cancer. That means the breast cancer had spread onto the cervix. Very surprising, And then when we checked the breast, there was actually a breast cancer there. That's why when you see a gynecologist or any doctor, and if you haven't checked your breast for a long time, and the doctor say, look, can we have permission to check your breast? And you've not checked it for many, many years, it is good to check your breast because sometimes by the time it becomes painful, it's stage 4. Most of the breast cancers happen when it's very early. There's normally no pain. So, but of course, for the women, it's very shy for them to let us examine the breast, but sometimes no choice. Next slide, please. Now, of course, we have to rule out bleeding from hemorrhoids. Some patients may make a mistake that is a bleeding from the vagina, but actually is bleeding from some piles, some hemorrhoids, Or it could be a urethral caruncle. That means there's something in the passing urine part, there's a swelling there. It's called a urethral caruncle. There's some bleeding, something that can stain the underwear with some blood. That's why the doctor has to check. Next slide, please. Now, what do we do if we think that our grandmother or our mother or our auntie or somebody that we know has got postmenopausal bleeding? First and foremost, we must confirm it. That means very often people they will take some time to see the doctor. They had bleeding 3 months ago. They didn't tell anybody, Then they had bleeding a little bit again, but they didn't tell anybody. Only later, they will talk to the daughter and say, actually, I had some bleeding, but that's 4 months later. Then by that time, she got no bleeding. So when you go and see the doctor say, are you sure you're bleeding? So if there is any bleeding, it's good to take a picture, or actually to keep the tissue with the blood and put it in a small plastic bag to bring to the doctor to show that, say, look, this is blood, and I'm already menopause 2 years, this is not normal. Can you please check me, So the other thing is sometimes some patients will say, look, there's actually some tissue came out, some flesh, So, and then they threw it in the toilet bowl and they flushed it away. No, don't flush it away. Take the piece of tissue, put it in a plastic, put it in the freezer if you want, and then bring it to the doctor so he can send it for testing. Then maybe it save you a DNC if it shows that there's something there. But you need to go and see somebody. Either talk to your family, go and see your family doctor, go and see a gynecologist, go and see a gynecologist, go see somebody. Don't just keep it to yourself, because postmenopausal bleeding is a sign that something is happening. And if you detect early, if it's stage 1, the survival is very, very good. It's more than 90%. Next slide, please. Now, what does the doctor do when we see you? Of course, we have to confirm that there's bleeding. We have to confirm where is the bleeding coming from, how severe is the bleeding, and the color and the smell. Is there anything else? Is it heavy? Could it be something else? Is it possible you are taking some medicine which you don't know now? Recently, I have seen some patients who are taking placenta tablets. They actually spend 2,000-3,000 a month to buy placenta tablets from New Zealand, or some other country, and they take 2-3 tablets per day to keep them looking younger, because the placenta contain hormones. But these hormones, unfortunately, they trigger the bleeding. I had one young lady who is 20-something who took these placenta tablets, and she had irregular bleeding, very irregular bleeding, And when she stopped it, the bleeding stopped. So we have to ask all these things, right? Next slide, please. Okay, so when we talk about postmenopausal bleeding and endometrial cancer, there is often a kind of a triad, meaning they are obese, a little bit high on the body mass index on the BMI. They usually have hypertension. They usually have diabetes, usually, right? So when you have a lady who comes with irregular bleeding or perimenopausal bleeding, or for example, postmenopausal bleeding, and they are slightly, say 90 kilos, or they have got diabetes, or they have got hypertension, then have to be careful. You cannot tell them, don't worry, go home and take some vitamin C, You have to check thoroughly, because they have a very high association with cancer of the uterus, especially endometrial cancer. Next slide, please. Now, as I mentioned, placenta tablets, many people are on it, and they say it helps them keep young and the skin is nice and they don't have to take hormone replacement therapy. So, and very often the patients don't tell you, In fact, the patient that I saw who took the placenta tablet, they never told me, until after 2 or 3 weeks, after I've seen them. Then only they slowly told me they actually took placenta tablets. Then only I found out. So that is the thing. Next slide, please. So why is it that endometrial cancer is linked to high weight, like 90 kilo, 100 kilo, or 85 kilo, rather than a 45 kilo patient? Why? Why is it so? Let's see at the next slide. The reason is a lot of the estrogen in our body is actually formed in our fat cells. It's actually formed in our fat cells. So when we menopause, the ovaries have stopped working. But because we have excess fat in the body, a certain chemical that is called aromatase will change certain of the hormones like androstenedione in our body that is naturally in our body into estrogen. And that triggers the stimulation of the lining of the womb. And that causes, if it's prolonged stimulation, because of the conversion in the fat cells that we have, that stimulates the lining of the womb, slowly, it becomes cancerous if we are not lucky. Now, what are the risk factors for endometrial cancer that can cause postmenopausal bleeding or irregular bleeding? Who is the youngest patient I've seen with endometrial cancer? The youngest I've seen is 34 years old. 34 years old. The oldest I've seen is about 80 something years old with endometrial cancer and irregular bleeding. So obesity, as I mentioned, because of the fat cells. If you take certain hormone tablets, which are estrogen, and you take it alone without anything else, that can stimulate the lining of the womb to cause cancer. If you have early menarche, that means you had your period coming at the age of 9, rather than the age of 13 or 14. Or you have late menopause, that means even at 58 years old, you're still having period. You are at higher risk of endometrial cancer. Patients with PCOS, patients with diabetes, patients with a family history of endometrial or colorectal cancer. Perhaps the patient herself had breast cancer or ovarian cancer in the past, radiation therapy, and maybe sometimes some of them have had endometrial hyperplasia a couple of years ago, and they never really treated properly. They thought the bleeding stopped and then they didn't do anything. So that are the risk factors. There are many other risk factors, like for example, the food we eat, all the preservatives and all the coloring, all those things may have an impact. Next slide, please. Okay, next slide, please. All right, we have to examine, take history, we have said that. Next slide, please. Now, what do we examine for? When you see a doctor and you are menopausal and you have bleeding and it's proven, you brought the tissue, you brought the blood stain underwear to the doctor's office. Of course, he needs to look at you. He needs to take your weight and height. He needs to look for signs of weight loss. Maybe you were previously 90 kilo, now you're 75 kilo. Maybe you look anemic. Maybe you got lack of blood. Maybe you've got some enlarged lymph nodes in the neck. Maybe we need to check your lungs and heart and the breast and everything as well. And we have to check the rest of the organs, especially the vagina part, the cervix, where you pass motion. Sometimes some patients are not lucky. The cancer may have spread to the passing motion part, may have spread to the vagina, and the uterus may be a bit affected already, and the surrounding tissues. So we have to check all those things. So to do a speculum examination, the vaginal examination is important. And then we need to look for any other tumor anywhere, not the vaginal wall, in the outside skin, in the lymph nodes. Very important. So you must forgive us if we check you, and we check you very thoroughly. Next slide, please. So what do we look for when we do an internal examination, a private internal vaginal examination? We look and see whether the uterus is Brca. When somebody is menopause, say for 5 years, how big is the uterus? It's very small. 2 cm, 3 cm, 4 cm, very small. But for somebody with a growth, a cancer, for example, or something abnormal, if you're menopause 2 years, 3 years, the uterus is quite big. Maybe it is about 10 cm, 12 cm, 16 cm, 20 cm. So when we examine, we can feel it. Even with the abdomen examination, we can feel the uterus. When you're actually 69, uterus should have shrunken, but it hasn't shrunken. We also look whether the uterus can move or not. If it can move, it's good. If there's something there, it's operable. If it's stuck, very stuck, we can't even move it, that's not a good sign. And we also have to look at all the tissues surrounding it. There's something called a parametrium. There's something called a pelvic side wall. And of course, we have to look at the cervix. Is the cervix normal or not? Because the endometrial cancer can invade the cervix, or once in a while, the cervix cancer can invade the lining of the womb. Next slide, please. Next slide, please. Okay, so the pelvic side walls will tell us whether it is going to be a good operation, whether the operation will take 1.5 hours or it will take 4 hours. So we also have to look at the area between our legs. There's an area called the inguinal area where the lymph nodes can be enlarged. And we have to determine, is it operable or not? Are you fit for operation? You may be 65 and fit, or you may be 65 and not fit. Then we have to decide what to do. Next slide, please. So there are certain tests required: basic, advanced, and definitive tests. Next slide, please. Now, the standard test would be to check your blood, whether your blood enough, the full blood count, your kidneys, your liver, the cancer markers, the pap smear. Sometimes patients ask me, doctor, I'm already 65. Why do you bother to do a pregnancy test? Is it possible I'm pregnant or not? Usually, we are not really testing for pregnancy, but some rare tumors may cause the pregnancy test to be positive, although you are not pregnant. And if it is positive and you're not pregnant, actually that is not a good sign, but we need to know because the management is different. So if we do a pregnancy test for you when you're 65 or 69, please forgive us. There's a purpose to it, right? Because it makes it different and it makes it a different kind of cancer, if there is, right? Of course, we have to check the cancer marker CA125, which can be raised in endometrial cancer, but it can be raised in certain other conditions. And cancer markers is not 100%. That means somebody may have cancer, but the cancer marker can be normal. Somebody may have no cancer, and the cancer marker can be 300. So we have to check. And of course, if you are 65 or 69, we have to do an ECG to see whether your heart is fit or not, if you need an operation. And a chest X-ray, some patients may be lucky, the chest X-ray is normal. Some patients, there may be actually some black spots on the chest X-ray. Okay, next slide, please. I got to hurry up because my time is running. Yes. So, of course, ultrasound, PPAL, as I mentioned, which is an office procedure, but it's not 100% accurate, a CT scan or MRI. Next slide, please. So, the gold standard to diagnose endometrial cancer or endometrial hyperplasia is to do a DNC with a hysteroscopy. That means we put a small camera in to the cervix there, look, and then we wash out and take the tissue and check whether there's cancer or not. Now, I had a patient who had post-menopausal bleeding. She went to 4 different hospitals. She was 60 something, and all the 4 hospitals did a DNC on her. All the 4 DNCs was negative. So by the time she saw me, it was almost 1.5 years of her bleeding. She's menopause, definitely menopause. She's 65, 60 something. And she still continued bleeding despite the 4 normal DNC. So when I did the 5th DNC, we found the cancer cell. We operated on her, the results were good, and she survived. So if you have persistent bleeding, even if the tests are negative, you cannot stop there. Next slide, please. Right, so hysteroscopy DDNC is the gold standard. Next slide, please. Okay, so this is a picture of somebody with a polyp in the cervix, in the uterus. This was after we removed it, and this is what we found. So when we do operations, after removing, we have to check to see whether there's something there, because we have to proceed to remove the lymph nodes if we find that it is not a good thing. And we have to check everything so that the operation is done carefully. Yes, next slide, please. Now, there are various types of endometrial cancer, endometrioid, uterine papillary serous carcinoma, carcinosarcoma, transitional cell, adenosquamous mix, and poorly differentiated, and a few others. But these are the main ones. So when we have done the DNC with the hysteroscopy, this is what we look for. Is it normal or not? All right. Now, if it's normal, but you're still bleeding, that means we haven't solved the problem. Next slide, please. Okay, there are grades of tumor. Grade 3, poorly differentiated, no good. Grade 1, good, but it's still cancer. Next slide, please. Now, as I've mentioned just now, why is it that the high body mass index is related to a higher chance of endometrial cancer? As I've mentioned, the fat cells in the body changes certain hormones in the body into estrogen. And if you're menopause, if you've got too much estrogen, that's not good for the body. Next slide, please. Okay, so this is the endogenous peripheral estrogen conversion from the fat cells. Next slide, please. Okay, so this is a timeline when you have persistent estrogen coming in. When you're not supposed to have estrogen, it causes changes in the body. Next slide, please. So what is the definitive management of endometrial cancer if it's proven? You need to assess the patient is fit for operation. If she's fit and she's agreeable, the family has been counseled, everything has been done, her heart has been checked, CT scan done, MRI done, we have got the report there which shows she has got something bad there, then she needs to have the uterus and the ovaries and the tube removed and some lymph nodes to make sure it hasn't spread. And any other tumor tissue when we do the operation, which is done very carefully and in good hands, they survive the operation and they do very well. Okay, and of course we have to remove the parametrium and we have to dissect out the ureter so that we won't damage it and we will preserve it and she'll be good and she will walk the following day. Most of my operations, you operate today, you will walk tomorrow. Next slide, please. Of course, post-operation care is very important, right? If she's diabetic, control it. If she's hypertensive, control it. We will have to ask the diabetic and the hypertension doctor to come in. We have to prevent venous thrombosis. We have to make sure the wound care, antibiotics are taken care of, and she walks very fast to prevent DVT. Next slide, please. Right. And then, of course, we have to wait for the report. The reports nowadays come back very fast. Within 3, 4, 5 days, the report is there. And we can tell you exactly what we have removed and whether it's good news or bad news and what kind of tumor it is, whether it's spread or not, whether the margins are good or not, whether there's any infiltration of the cancer cells into the small blood vessels, which is called lymphovascular space invasion. And then we have to grade the tumor. We have to see whether it's spread into the body of the uterus, myometrial imaging. Okay, I think I have to finish very soon already. Next slide, please. So we have to decide whether you need chemo or radiotherapy or we leave you alone. Next slide, please. So we need to stratify the risk. We need to counsel the family and the patient, looking at the report and her overall condition. Next slide, please. Okay, then we have to decide what to do, right? As I said, next slide. Does she need chemotherapy or radiotherapy? So this, we will have to look at it. Sometimes we ourselves have to go and discuss with the pathologist what exactly they found. What are the bad features and what are the good features? And then we decide together with the patient and the family for good results, long-term results. So you will live for the next 10, 15, 20 years, 30 years maybe. Next slide, please. Okay, this is a picture of a uterus that's removed. Next slide, please. This is an operation done by me. This one is tamoxifen. Patients with breast cancer on tamoxifen. Next slide, please. So when you are on tamoxifen, you sometimes may get irregular bleeding. So you have to be seen by a gynecologist to check the lining of the womb. Is it very thick or not? And what we need to do. We will advise you. Next slide, please. Okay, and of course, follow-up post-surgery is important, very close follow-up to make sure that if there's any early cancer coming back, we can detect it very fast. Next slide, please. Okay, have to be very meticulous from the beginning to the end so that we do not miss anything. No stone unturned. Next slide, please. PET CT scan, I'm sure many of you have heard about it. It uses glucose and the fact that cancer cells take up glucose and we detect where is the uptake of glucose. Next slide. To detect cancer recurrence in those who have been operated and treated. That is what we have to do, cancer surveillance. Next slide, please. So as I've mentioned just now, we always have to bear in mind other diagnoses. Next slide, please. And next slide. Next slide. So I'd like to thank you. I'd like to thank all the members of my team and all my colleagues and everybody else, especially my patients. Thank you very much. Thank you. Thank you.
Thank you, Prof. Eugene, for the sharing session. So without further ado, I would like to introduce our next speaker, which will be Prof. Dr. Chong Pei, who is the head of research at the Faculty of Health and Medical Sciences in Taylor's University. She graduated from University of Manchester with a first-class honours degree in biochemistry and later went on to pursue a PhD in the same university. She received full scholarships for both the undergraduate and postgraduate degrees. And prior to joining Taylor's University, she served in UPM for many years and she began her career as an academic, starting with the position of lecturer in Faculty of Medicine and Health and Sciences. She has been actively involved in collaborative research such as links between genetic polymorphism and cancer, risk for virus-associated cervical cancer, and more recently, prostate cancer. Her current research interests include transdisciplinary research that encompasses multiple fields that span engineering, IT, biological sciences, and in the quest for improved healthcare for the woman especially. She has an active FRGS grant and as well as a PRGS grant from the Ministry of Higher Education as principal investigator, which is focused on improving Pap smear device and image analysis procedures using new technology. Today, Prof. Chong Pei will be sharing on the topic making Pap smears more accurate and friendly. Now I invite Prof. Chong for her presentation.
Thank you, Guhan, for the kind introduction. Let me just share my screen. Okay, are you looking at my PowerPoint?
Yes, Prof. Can see it.
Okay, all right, thank you. Okay. Full screen, just give me a minute. Let me swap the presenter view. Okay, all right. Thank you for inviting me to give a talk at this webinar. So my title or my talk today is how to is making Pap smear more friendly and accurate. Yeah? Okay, a bit of background about cervical cancer. So cervical cancer is, of course, cancer of the cervix, and it's the most common cancer among women, especially in the poorest countries. But nowadays, of course, there is a shift in terms of the cancer incidence for cervical cancer. So it's very low incidence actually among women in developed countries. So there is a huge disparity there for the poor countries and the developed countries. Cervical cancer has been shown to be associated with the human papillomavirus or HPV. And in fact, it is the persistent HPV infection which has been known to be causing the cervical cancer. So if cervical cancer can be detected early, then it would be prevented entirely. And we can do this by having regular Pap smear tests. And so if it's detected early, cervical cancer is actually one of the most treatable cancers. Okay. I'm having trouble controlling the slides. Sorry about that. Okay, I think it's better. All right, so a little bit of introduction about how HPV infection actually leads to cervical cancer. So as you can see in this slide, so HPV infects the epithelial cells in the cervical mucosa. And at this point of the infection, actually it can resolve on its own due to our immune system response. However, upon viral replication, if a lot of the cells actually get infected and there's transformation, cell transformation, which will happen gradually, not immediately, but gradually over a long period of time of about 10 to sometimes 30 years, then you will develop cancer. So only about 0.8% eventually develop cancer, with the majority of the HPV infected individuals healing within 2 years of the infection. So let's look at the cervical cancer global incidence and mortality. So cervical cancer was the 7th most common cancer in the world. and the fourth most common cancer among women in 2020. More than 600,000 women were diagnosed with cervical cancer, and there were more than 340,000 deaths caused by cervical cancer in 2020. But 10 years ago, cervical cancer ranked as the third most common cancer among women worldwide. And in 42 low-resource countries, it was the #1 most common cancer in women. The Global CAN statistics estimates that about 530,000 cervical cancer cases were detected in 2008, and there were 275,000 deaths. And the important thing here to note is that 85% of the cases occurred in the less developed countries. And these were found in the Sub-Saharan Africa, Central America, South Central Asia, and Melanesia. So if we look at the map of the world, okay, the most concentrated parts of the world with high incidence of cervical cancer is, of course, the poorer countries or the developing nations, with the darker blue shades here in Africa, South America, and some parts of Asia. And the mortality also is about the same picture as the incidence. So this was in 2015. Okay. Fast forward to 2018, the picture hasn't changed much. So this is the age standardized incidence for cervical cancer by country, and you can see about the same distribution globally. So the standard screening test for cervical cancer is the Papanicolau PEP test invented by Dr. George Papanicolau, which detects abnormal changes for precancerous lesions and also cancer cell transformations. Other than Pap smear, we have liquid-based monolayer cytology. So Pap smear is actually the conventional cytology. And after Pap smear, we have the liquid-based monolayer cytology, which I will be explaining a little more towards the later part of the presentation. And another test that we can do is the human papillomavirus or HPV testing, and also visual inspection with acetic acid to directly inspect the cervix to detect precancer or cancer. So there's WHO actually has some recommendations for the PEP screening, namely that women aged between 30 to 49 years old to be screened at least once or more often, and for the lower or higher age groups according to the national programs or policies. So I'll be alluding to the differences about the Pap smear screening scenario in different countries. So in Malaysia, so cervical cancer is the third most common cancer among women, with 45% of the women diagnosed in late stages. And various studies have shown that the cervical cancer screening uptake rates remain very low in Malaysia, and due to various reasons. In Malaysia, actually, the Ministry of Health had initiated the Pap smear screening since as early as 1969. But the National Health and Morbidity Survey in 2011 had found that only 12.8% of eligible Malaysian women had a Pap smear examination done in the past 12 months. So what happened there? So we have this National Strategic Plan for Cancer Control Program, which recommends that Pap smear screening should be continued. And we have the Lembaga or LPPKN, which takes care of the family planning. And they also play a vital role for Pap smear screening of women. Then if you look at the developed countries, the developed countries have adopted a systematic population-based screening program, especially in UK, Australia, Italy, Sweden, and others, where the program incorporates a call recall system. So for example, in UK, the NHS would actually send a letter or email or message to the women who are eligible to come for their Pap smear screening appointment. So this has ensured the success in increasing Pap smear screening test coverage. Whereas in Malaysia, we are adopting the opportunistic screening, whereby women are usually screened only their visit to maternal and child health care or the reproductive health care clinics. For example, post-delivery. So it's very ad hoc and not a systematic approach. So if you look at the Pap smear uptake rates in Malaysia, so this is a study done by these authors here. So for women who had never had Pap smear test done before, so this was from a total of 320 respondents, 72.5% never had Pap smear test done before. So this is amazingly high. And prevalence of non-adherence to the Pap smear screening advice and a recent Pap test within 3 years, you can see also again is very, very high at 90%. So what are some of the barriers to cervical cancer screening? So fear is one of the major top reasons why women do not participate in the Pap smear test. So fear, including the pain, this is both in those who had a Pap smear test done before, as well as those that have not or have never had Pap smear done before. So fear is one of the top reasons. Embarrassment is also one of it. And also fear of the Pap test results, right? And some of them is because their lack of knowledge or awareness and require more information about the Pap smear test itself. So what are the tools that are available for conducting the Pap smear test? For the clinicians administered cervical sampling, these are the tools that are commonly used. So we have the combined spatula with the Ailes end, a standard tip above, and the Aile end below here. We also have this endocervical brush that looks like a bottle brush, and this is the cervical broom, which is a bit soft and not as painful if you use this. Okay, so this is how the Pap smear test procedure is done. So the clinician would insert the speculum to sort of open up the cervix a bit, the vaginal bit, and then insert the sampling device. Okay, besides this clinician initiated or clinician administered sampling, we also have some self-sampling devices because some women find the procedure of gynecologist administered cervical sampling intrusive and embarrassing. So these self-sampling devices have been invented. So for example, we have the swab sampler like this one. We have tampon self-sampler, as well as the cervical vaginal lavage self-sampler. For the swab self-sampler, there is a higher rate of microscopic blood contamination, which if you are intending to do a Pap smear test as well as a HPV DNA test, then it could interfere with the HPV test results. So we also have this Evalin brush, which is shaped like this. If you push down the piston, this end here, it will open up like a petal, and then you can turn, rotate, and then collect the cells. All right, it's a bit more comfortable to the women in terms of the feel and also visually less intimidating. This is the Delphi Screener. So this one, as you can see, it has a rounded, smooth surface and tip. So this is meant more for the HPV test and not really for Pap smear because the tip is smooth. In Malaysia, we also had someone from UKM in collaboration with UPM, I think, also invented a self-sampling product. So they call it the servicing. Okay, but this is more meant for HPV tests as well. Okay, since the HPV test is now available and the WHO actually sort of recommends HPV tests preferably, then is there still a place for Pap smear? That's the question. So from the scientific point of view and from the knowledge about how cervical cancer actually develops from HPV viral infection, I think there is a general misperception about HPV positivity equals to cervical cancer. So that is definitely wrong, because a woman who is positive for HPV DNA does not necessarily mean that she has cervical cancer. Because as I shown just now in one of the slides about the progression from HPV infection until you actually eventually develop cervical cancer, it takes decades, right? And also at the early stage, if you have HPV infection, your immune system may be able to eliminate the infection naturally. So therefore, in my opinion, there's still a place for Pap smear test. And I will also support this argument with some publications and articles later on. So in the beginning, if you have normal cervical cells, so this is the chance that you should introduce vaccination, especially to the sexually naive females, those who are teenagers or pre-puberty children. And then when it comes to when they become sexually active, okay, because HPV is sexually transmitted, then this is where there's a chance for HPV infection to occur. So this is the time that you can introduce the screening, be it HPV screening or Pap smear screening. Then, so this could take years to decades. So now I have done some research on HPV prevalence in Malaysian women. So we use an ultra-sensitive nested PCR method that captures all the HPV types. For your information, there are more than 100 HPV types, although not all HPV types will lead to cervical cancer. Only the high-risk HPV types will lead to cervical cancer. The low-risk types may lead to some other benign lesions, like warts and some other conditions. So in our research, because we use the method that captures all HPV types, we detected a very high prevalence, about 40% of HPV among healthy. So many women are having HPV, whether it's low risk or high risk, then if you do the HPV test across the board for women, you are going to get a lot, and these women will come with, when they hear their results, they will be very anxious. This high anxiety. You will, as a physician, you will also have a busy time trying to explain to them what is the real scenario. So I think there's still a case for doing Pap smear, right? Because Pap smear, you are directly observing whether there's any abnormal pre-cancer or cancer changes in the cells. And then in 2015, I also did research together with my ex-colleagues in using cell sampling device. So we found that it can serve as a use. et al. Found that 83% of the cervical cancer patients and 0% of cancer-free females had HPV DNA. All right. But then these females were tested with Pap tests. Okay, they were tested as Pap test negative. So that explains why 0% had HPV. Had HPV DNA because they screened using Pap tests already. Okay, Ramat et al. Found that prevalence of HPV infection was 14% in 764 women from various cities in Malaysia. Majority of the HPV detected in women. Again, look at this. In women, the most common high-risk HPV type that they found in Malaysia is HPV 52. So this is a different scenario from the European countries where they find that the commonest HPV type were HPV 16 and 18. So in the past, the HPV vaccine did not cover HPV 52. But fortunately, in the past 2 or 3 years ago, I think, we had a new vaccine, Gardasil 9, which could protect against HPV 52 as well. Okay, so what can we do to close the gap between cervical cancer screening in the developed countries compared to the developing countries? So, could increase awareness through mass media smear, but of course this will incur a lot of costs for the health authorities. So another consideration is whether we want to make Pap smear screening mandatory. For example, if you look at the other situation for childhood vaccinations for babies until the school-going age, certain vaccinations are compulsory and they need to show their vaccination record. And for the school children, oftentimes when they have missed certain vaccination, then the health authorities will actually come to the school and administer the vaccination. So could there be a way that we could emulate this childhood vaccination programs for the cervical cancer screening, the primary health services, and also maybe some of the other ways would be to innovate the Pap smear screening tools so that they would have more modern design, more user-friendly, and inflict less pain on the women. Another way is to automate the process of Pap smear image analysis. using computer interface like AI or deep learning platforms. So why do I say that? Okay, let's look at the next slide. So how accurate are Pap smears? So the Pap smear procedure is done like this. So first of all, the gynecologist would collect a cervical sample that contains precancerous cells in this, and over 80% of the collected cell samples are actually still stuck onto the brush and they are discarded. So these smeared cells are then spray fixed and then sent to the lab. So the cytotechnologists or the pathologists will examine the microscope slides and then look at the cells, whether there's any abnormal cells. But with this method, there is a lot of missing cells, and sometimes the cells are overlapping each other in multiple layers. So it would limit the accurate diagnosis. In fact, Pap tests have reported to have false negative rates of 10 to 20%. And sometimes repeat testing may be necessary if some abnormal cells are detected. So liquid cytology was then invented, and this is where this brush that have collected the cells is vigorously rinsed in a liquid in a vial. Okay, this is called a tin prep vial. And this vial is then immediately preserved and sent to the lab where there is a filtration process and concentration process that sucks the cells down towards the slide, and they are focused now into an area on the glass slide about a 20 cent coin area size. So then these cells are then more dispersed and randomized. Okay, so yeah, this is my conclusion. So Pap smear is still a very useful, Pap smear is still a very useful cervical cancer screening method. And although the Pap smear uptake rates in Malaysia still fall short of the ideal situation, in recent years, I can see that there's a lot of campaigns to increase awareness, and also public health screening campaigns have been carried out, and I've also personally participated in some of these health screening campaigns in the rural areas, especially in the kampong areas. So this has greatly helped in boosting the Pap smear uptake rates. Improvements can be made to reduce the false positive as well as false negative rates of Pap smears through innovation on the guided image analysis. So some of the current research projects that are carried out at Taylor's University by myself and also my colleagues from the School of Medicine, notably Dr. Kai, and also from School of Engineering and School of Computing, include to innovate a more user-friendly all-in-one Pap smear sampling device. So we actually won the prototype research grant scheme for this project where we're collaborating with School of Engineering using 3D printing to create the prototype new device. We are also collaborating with the School of Computing to develop a deep learning algorithm using neural networks excuse me, to automate the process of PET image analysis. Because at the moment, the PET smear images are analyzed by pathologists, and being humans, we sometimes could make mistakes. So we try to automate the process. So that's all for my presentation. Thank you very much. Okay, any questions? You're welcome.
Thank you, Prof. Chong, for the
Thank you.
informative talk.
Pass the time back to Kuhan.
Okay. Thank you, Prof. Chong, for the informative talk. Dear participant, now we can begin the Q&A session. So please type out your questions in the chat box for the speakers to answer. I think so far there's no questions. There's only one question just now to Prof. Yip, and she's already answered it. Is there any other questions for Prof. Eugene and Prof. Chong? Prof, I think if there is no questions, then we can just end it.
Yeah, go. Yeah, go ahead. Go ahead.
Okay.
Just thank you everybody for coming. Yeah.
Okay then. Okay, so for those who would like to claim your MMA CPD's points, please scan the QR code that I'll be showing soon on the screen. And if you're unable to scan the QR code, you can go to the link shown in the slideshow later, and you can go in and fill in the form, and we can get your details and claim the CPD points for you. So this is the QR code to scan to obtain your MMA CPD points. And if you're unable to scan the QR code, you can go to this link.
Okay.
I will just leave the screen on for about a few minutes.
We have a question there. Will endometriosis lead to endometrial cancer? I think endometriosis itself doesn't lead to endometrial cancer, but endometriosis can lead to something else, like endometrioid adenocarcinoma of the ovary, but not per se endometrial cancer by itself. Okay. I think, Kuhan, if there's nothing else, I think I can close it.
Prof, then can we end the meeting?
Okay, I would like to use this opportunity to thank the speakers and the organizers for their support. Also, a big thank you for all the participants. We really appreciate your attendance and we hope you enjoyed this webinar. Thank you. Also, I will upload a recording of this into the YouTube channel.
Thank you so much, Kuhan.
Thank you.